Welcome to this first webinar organized by the Network to Improve Quality of Care for Maternal, Newborn and Child Health. My name is Bernadette Dalmans and I work in WHO's Department of Maternal, Newborn, Child and Adolescent Health. As part of joint learning, the network management team hosted by WHO will convene regular webinars, the dates and topic of which will be announced on the Quality of Care website. Today's webinar is dedicated to improving healthcare for pregnant women and newborn, and our guest speaker is Nigel Lesley, Regional Director, South Asia of the USAID Assist project. To remind ourselves about the network, I'd like to share a few slides on the vision, principle, and objectives that bind us. First, our vision, which for every mother and newborn is to receive quality of care throughout pregnancy, childbirth, and in the postnatal period, as part of larger efforts that governments are pursuing to achieve universal health coverage and towards ambitious new targets formulated as part of the Sustainable Development Framework to end preventable maternal and newborn mortality and stillbirth. The definition of quality of care is summarized in this slide, which describes 6 critical attributes of quality care, namely that it is safe, effective, timely, efficient, equitable, and people-centered. The conceptual framework that is part of our network provides the foundation for our quality improvement efforts. The centerpiece in this slide summarizes 8 domains in which actions are required to ensure quality of care. Each domain is annotated by standards with quality statements and measures that describe the quality of care. On the left side, we see domains that specifically pertain to provision of care, while on the right side, we see domains that pertain to experience of care. Both provision and experience are essential for the outcomes that we intend to achieve at individual and facility levels to happen. To translate this conceptual framework into practice, 4 objectives have been identified to drive the work of partners in the network. Leadership, to build and strengthen national institutions and mechanisms for improving quality of care in the health sector. Action, to accelerate and sustain implementation of quality improvements. Learning, to facilitate learning, share knowledge, and generate evidence of quality of care. And accountability, to develop, strengthen, and sustain institutions and mechanisms for quality of care. Finally, I'd like to introduce the implementation framework that summarizes the steps through which we can operationalize these objectives. At the top, we see a systematic series of steps, starting with national policy, strategy, and structures, which then lead us to steps that ends with the PDSA cycle, the cycle of plan, do, study, act at the level of health service provision. In our session today, Nigel will introduce us to the implementation interventions that have shown to be effective to improve quality of care and illustrate how we can move towards the network's goal of reducing 50% of maternal and newborn death and stillbirth in health facilities that are part of the network in 5 years, using a concrete example. Nigel, the floor is yours.
Great, thanks Bernadette. So I want to start with a story from a single hospital in India. And this is data showing the percent of women who came to the clinic, how many of them got their blood pressure and their hemoglobin measured. And as you can see, it's not great. Everybody should have got their blood pressure and hemoglobin measured, but around 50% did. And this is pretty typical for clinics all over the world, for basically any technical area. Most patients don't really get the care that they should get. And this is the point of this network, to try and fix this, to make sure that all of the great interventions and diagnoses and techniques that have been developed over the years are actually applied to the patient who needs them. And so WHO has done a literature review to look at what interventions help make sure that patients get the care that they should get. And they've come up with 8. Leadership and governance, system redesign, using financial strategies, providing resources, engaging women and their families in care, training and education, using data to support improvement, and forming learning communities. So these are 8 tools that we can use to make sure that patients get the care that they're supposed to. They don't all work in the same way, and they don't all do the same things. So let's just go through that a little bit. So the point of this network is that in the facilities that we're supporting, we achieve a 50% reduction in maternal and newborn deaths over the next 5 years. Now, the only way for that to happen is if something different happens between the provider and the patient, right? So if people get the same care in 5 years that they do now, we won't see any reduction. We have to change what happens at the level of the patient and the provider. And what happens at the level of the patient and provider is governed by 3 things. It's governed by resources, skilled and motivated health workers, and then also processes that are used to deliver care. So to get a better interaction, we need to be able to change those 3 things to make sure that resources are better, that health workers are more skilled and more motivated, or to make sure that the processes are better. So if a leader wants to put in place efforts to reduce mortality, he or she can use the different interventions to try and address resource, skills, or process issues. They're tools that can be used to make sure that the interaction is better. The one intervention that is a little bit different is engaging women, families, and communities. That is a tool to make a better interaction, but it's also useful in and of itself. Right? If we're providing care to a human being, that human being should be engaged in what that care looks like and how it's delivered. So it's useful to engage women and families in their communities, and that's going to be useful for getting a better reduction in mortality, but it's essential to provide respectful care. So this is all a little bit theoretical. Let's come back to the real world and talk about how this sort of thinking can apply to the problem that we've been talking about. Okay, so we have a problem in a clinic that we'd like to fix, and we have 8 different strategies that could potentially help. How do we decide which one to use? This is a good place to start. You know, we want to find out if the problem is related to appropriate resources, skilled and motivated health workers, or to the processes of care. And all of those are possibilities, but they would require different interventions. So if the problem is a resource problem, you know, the nurses lack equipment or supplies, then the right approaches would be to provide the resources or to use some financing approach so that people can get the resources themselves. The problem could be individual performance, that the nurses aren't doing their job because they lack knowledge, they lack skills, they lack respect or empathy for the patient, or they lack motivation. If those are the problems, then the approaches you could use would be training to build knowledge and skills, involving women or communities to improve respect and empathy, using supervision or financing or leadership to address respect or motivation problems. Another option is that this is a process problem, that the nurses have the equipment and they have the knowledge and the skills, but something in the way that the service delivery is organized is making it hard for the nurses to do their jobs. And if that is the problem, then system redesign and using the data to find the problems would be the right approach. So when we look at data like this is 6 months of aggregated data. We don't know which the problem is. So that would be the next step, trying to figure out what we should be doing. So instead of looking at data over 6 months, it's useful to look at it in a disaggregated way. And that's what this clinic did. They broke it down and they looked at data every week. And so if you look at the third week in October, no woman had her blood pressure measured. Almost every woman had her hemoglobin measured. The following week, no woman had her hemoglobin measured. Every woman had her blood pressure measured. So this is the same clinic with the same resources and the same nurses. So it's really impossible that this is a resource or an individual performance issue. This is a process problem. There is something in the way that the clinic is set up that leads to chaos. Some weeks you have quite good performance and some weeks you have really bad performance. So let's go into some detail about what that process problem was. So this is what the clinic looked like. There's a room with 6 nurses stations, and the patients come in and they go to any one of the nurses, and the nurse carries out all of the different tasks of the antenatal care visit, and then the woman goes. A challenge here was that there was only one blood pressure cuff. Okay? There were other problems as well, but there was only one blood pressure cuff. And so when the women come in and it gets busy, some of the nurses have to go and wait for the blood pressure cuff. And that means that they are not looking after the women at their station. The queues get longer, people complain more, people rush things, and the nurses kind of skip doing the blood pressure or other tasks as well. And so the clinic fixed this by changing the process. They just clarified what each nurse should do at each station, and they clarified how patients should move through the clinic. So for example, the first patient might first go and get her blood pressure measured, then go and get her lab tests, then go and get a history and physical, and then finally end up with some counseling and treatment stations, right? And there's no right answer for how to organize the care. The clinic had to figure out, you know, what is the best allocation of tasks and what is the best way that the patients should move through the clinic. So they spent a couple of weeks doing that. When they got it right, they were able to make sure that basically every woman got all of the services, and even more importantly, for the first time, women are really now being identified with high-risk conditions and then are being referred to the gynecologist and managed appropriately. Okay. So we have a lot of tools that we can use in healthcare, but we don't use them all. Right? People's first reaction to a problem with quality of care is to look for more resources or do more training. We don't really focus on processes as much as we can, but we are not going to get a 50% reduction in maternal and neonatal death if we're only using some of the tools that we can use to provide better care. And making sure that we're able to look at processes and fix process problems is going to be very important. So that's going to be the focus of the next 4 or 5 webinars, talking about some practical and simple steps that health workers can use to improve care by focusing on identifying and solving process problems. It's very common sense. These are things that you do in your daily life all of the time. But when we start working in a team in a health facility, we often don't follow these steps. So it's useful for having something systematic that health workers can use to improve care. So the 4 steps are, first, to identify a problem. Improving quality is too general. Reducing maternal mortality is too general. You want to fix a specific problem. We want to make sure all of the women who come to the clinic get their blood pressure and hemoglobin measured. Once you pick a specific problem, you want to form a team and then write a specific aim statement so that everybody knows what you're planning to do. The second step is to make a diagnosis, to analyze why you're not getting the results that you want, and then also to set up systems to measure what you're trying to achieve so you're able to get regular feedback about whether you're going in the right direction or not. The third step is to do something different, to make a change and to test whether it works and whether it's giving you the results that you'd like. And then the fourth step is, once you've come up with changes that work, you put in place actions to make sure that they are sustained and that they will happen for everybody who comes to your clinic or into your ward. So the materials for these steps were developed by Ashok Deorare from All India Institute for Medical Sciences and Rajesh Mehta from WHO CRO and from USAID Assist staff as well. If you're interested in reading ahead, here are the links that you can use. And so the idea is that we're going to get to the 50% reduction in mortality by starting with small problems, quickly solving them, and building on and moving on to new problems. So this is an example of how this has worked in another facility in India. You know, this team started by making sure that all pregnant women got oxytocin after delivery and all babies got vitamin K in the first day of life. A couple of weeks later, they were able to fix these problems, so they started working on making sure that babies' cords were being cared for in a sterile way. A couple of weeks later, they had made progress on that, so they started working on breastfeeding, right? So it's taking a huge problem, maternal or neonatal mortality, chopping it up into small problems, and then applying a systematic approach to solve each of these small problems as quickly as possible. Right? And so having the skills to do this based on these 4 steps is useful. At a facility level, just the skills is not enough. So having a training on quality improvement isn't going to get as many results as you would like. The facility also needs to set up some structures to support this work. They need to form a quality improvement team, and they need to have the leaders of the institution support that and encourage it. And then perhaps the most important ingredient for success is the right attitudes. You know, it's not easy getting a 50% reduction in mortality. Doing the same things that we've always done are unlikely to get that. So we want to encourage health workers to be curious, to try new things to see what works, to be humble, right? To accept that it's not simple and to be questioning what they're doing and trying new things. We also want people to be optimistic and to keep trying and to collaborate both between members of the team in a facility and between facilities. So we've had experience in the past few years working in this way in India. We've been supporting over 400 facilities with a delivery load of close to 200,000 babies per year. And using these skills and these sort of attitudes and structures, these facilities were able to get a 15% reduction in perinatal mortality. Part of that was a 30% reduction in newborn deaths. So I think that the 50% reduction that this network is aiming for is completely feasible. So before I end, I just want to talk about carpentry for a little bit. So, you know, a carpenter's job, for example, might be to build a chair. To do that, he or she has a wide variety of tools that could be used to build the chair. If a carpenter comes to you and says, you know, I will build you your chair, but I am not going to use a saw or clamps or vices. I'm great with all of the other tools, but those tools I just don't use. You probably wouldn't hire that carpenter. So human beings are infinitely more precious and complex than chairs, and we have a variety of tools that we can use to provide better care to humans, and we should use them all. We shouldn't be stuck in our old ways of working, and these attributes that apply at the facility should apply to us as well. We should be curious, humble, optimistic, and we should collaborate so we can learn as quickly as we can and apply what we're learning to change the interaction at the patient level and get a 50% reduction in mortality and provide a better experience of care to the women and families coming to our services. Thank you.